Does it work? Yes. So hi everyone. So I'm really delighted to be here today to present our preliminary results on dipeptidyl peptidase 3, DPP3, in the field of cardio-oncology. Okay. Chemotherapy-induced cardiac dysfunction is one of the most important side effects of chemotherapy treatment in cancer patients. It is associated with increased morbidity and mortality. It can happen early or late, even years after completion of chemotherapy, and it obviously limits optimal anti-cancer treatment. But cardiac dysfunction in cancer patients can also be caused by cancer itself. Some experimental and some clinical studies show that cancer or tumors can induce decreased protein and heart mass, disrupted myocardial structure, increased inflammation and fibrosis, leading to, so it doesn't work, okay. Leading to a decrease in cardiac function. The hypothesis behind this phenomenon is based on molecules such as cytokines that are secreted by the tumor and that will cause the cardiac cachexia, inducing cardiac dysfunction. Now moving to DPP3. DPP3 is a metallopeptidase, zinc-dependent. Its known in vivo substrates are angiotensin 2, 3, and 4, enkephalins, and endomorphins. DPP3 is mainly cytosolic, where it plays a role in inhibiting oxidative stress, but it can also be present in the circulation of healthy and sick individuals. Our team showed the prognostic value of DPP3 as a biomarker in predicting mortality in septic shock and cardiogenic shock patients. At the experimental level, Benjamin Deneux showed that the injection of DPP3 into healthy animals will decrease the cardiac function. On the other side, the inhibition of DPP3 by using an inactivating antibody, the protizumab PCZ, will improve the cardiac dysfunction in 2 models of acute heart failure and septic shock. More importantly than now, is that DPP3 is highly expressed by tumors and cancer cells. And some studies show that DPP3 activity is associated with the histological grade of the tumors. Very recently, Tong and his colleagues show that silencing DPP3 in cancer cells before injections into healthy animals will reduce the tumor size and volume. On our side, what we've seen is that DPP3 protein and mRNA expression is overexpressed after doxorubicin treatment in the heart of mice or in vitro in cardiomyocytes. Our hypothesis is then that DPP3, which can be expressed by cardiomyocytes and or cancer cells, is implicated in cardiotoxicity induced by cancer and or chemotherapy. Big challenge. So we used 2 approaches, an in vitro one using cultured cardiomyocytes, ovarian cancer cells, and conditioned media, and another approach, which is an in vivo approach, developing an very acute and severe model of cardio-oncology induced by doxorubicin in wild-type mice and DPP3 knockout mice. Our results showed in vitro that DPP3 protein expression is overexpressed, is induced, in cardiomyocytes and ID8 cancer cells when treated with doxorubicin. And this was associated with higher mortality after those treatments in those cell lines. When now we treated those cell lines with DPP3, with 2 doses of DPP3, a lower one and a higher one, just for note, the higher one will look like what we find in the normal, healthy individuals. We didn't see any effect in survival of cardiomyocytes, but we observed that DPP3 tends to promote the survival of cancer cells. Moving now to the PCZ. So we first treated the cardiomyocytes. So on the left, we treated first the cardiomyocytes with PCZ and doxorubicin. And what we've seen is that PCZ slightly very partially, but significantly prevented the mortality, decreased the mortality induced by doxorubicin. Then moving to the conditioned media experiment, when we incubated the cardiomyocyte with the secretum of cancer cells not treated, we didn't observe anything, any effect on the survival of the cardiomyocytes. But when we stressed those cells with doxorubicin, we observed that this secretum can induce mortality of cardiomyocytes. Then what we did, we took the last experiment, so the secretum of cancer cells treated with doxorubicin, and we pre-incubated it with PCZ for 30 minutes before putting it on cardiomyocytes. And what we observed is that PCZ prevented the mortality induced by the secretum of cancer cells treated by doxorubicin. At the in vivo level, what we observed is that the knockout mice, the DPP3 knockout mice, presented with a more acute and severe heart failure just after the completion of the treatment. But those mice seem to recover their cardiac function, to recover their weight. And this was associated with less mortality than the one observed in wild-type mice. At the time of the sacrifice, which was 2 weeks after the termination of the treatment, which is obviously too late, we didn't observe significant differences in some markers of oxidative stress. To conclude, definitely DPP3 is implicated in doxorubicin-induced cardiotoxicity, but we need to consolidate. We need to do more and more experiments to understand the dual role of DPP3, which is probably linked to its intracellular and beneficial antioxidant effects versus its circulating inotropic negative role. Yes. I would like to thank my team, and especially Noma and Adrien, who performed mainly all the experiments. And thank you for your attention, and I'm happy to get questions.
Thanks, Feriel. Any question in the room? Any comment? Do you see any kind of possibility of target DPP3 in the next years to avoid chemo-related cardiotoxicity?
Maybe I think that what we are missing right now is the circulating DPP3 in those patients. We have really few data on circulating DPP3 in cancer patients, and it seems to be high. We still don't know if it is prognostic of anything, of survival or of cardiotoxicity, which would be the best outcome. But yeah, I think it's too early.
Okay. More comments? No? Thank you. Thank you, Feriel.